Guys, I will be talking about anti-retroviral therapy. Now, to consider HIV, it is a retrovirus, meaning it has the enzyme reverse transcriptase, which is also known as RNA dependent DNA polymerase. From this information, you can infer that RNA is the viral genome which is getting converted into DNA so as to cause infection of the human cells. Now, let's just understand HIV briefly. This is the structure of HIV. This particular part is GP120. The stalk is GP41. Both together are known as GP160. The outermost layer is called as the envelope. This is the capsid. This is the viral genome, which is single-stranded RNA. It has few proteins. I'll just mention the most important ones. Reverse transcriptase, and integrase, and protease. So that's RIP for you. You can remember it for the mnemonic RIP. Now, how does HIV infect the human cells? Now, HIV usually affects cells which express the receptor CD4. Okay, these can be your T helper cells or macrophages. Usually there is a co-receptor that is present, which may be CCR5 or CXCR4. Okay. Now, how does this happen? Your CD120 interacts with CD4 with the help of co-receptors, which are also known as chemokine receptors, which are namely your CCR5 and CXCR4. And then your GP41 initiates the process of fusion of the cell membranes of both the cells. Okay, so now you can inhibit these interactions. These interactions, the drugs which inhibit this interaction are known as entry inhibitors. Okay, for that we have enfuviratide, which inhibits GP41. We have fostemsavir, which inhibits GP120. There's also ibalizumab, which inhibits CD4 receptors. Okay, you also have lenacapavir, which inhibits the capsid. This is a capsid inhibitor. Okay, moving on. We have to first understand the replication of the HIV virion inside the T helper cell to understand the uses of other drugs. Okay, so how does the virion replicate inside the T helper cell or macrophage for that matter? So essentially, the ssRNA, which is the viral genome, now enters the human cell. This is all within the human cell. Alright, in that case, it first has to convert itself into DNA so that it can incorporate itself into the human DNA. And this is the integration of the viral DNA into the human DNA. So now the virus exploits the cell machinery to produce proteins and assemble itself to form a daughter virion. So again there will be a polypeptide formation that is cleaved to form different parts of the virion. Okay, so cutting and assembly of virion. So essentially we have discussed 3 steps here, which is reverse transcription, integration and protein formation, which is basically cutting and assembly of virion, integration and reverse transcription. Now very logically this will translate to your drug classes. For example, for reverse transcription, which is catalyzed by or mediated by your enzyme reverse transcriptase, we have reverse transcriptase inhibitors, which are nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, and non-nucleotide reverse transcriptase inhibitors. We have integrase inhibitors and protease inhibitors. Alright, now let's go back to the classification. So nucleoside reverse transcriptase inhibitors, and your non-nucleoside reverse transcriptase inhibitors, that is your class 1. You have protease inhibitors and integrase inhibitors. I'll just rub all of this so we can discuss the further drugs. Now when you're talking about nucleoside reverse transcriptase inhibitors, they will competitively inhibit your reverse transcriptase enzyme, whereas your non-nucleoside reverse transcriptase inhibitors will inhibit the enzyme non-competitively, meaning your nucleoside reverse transcriptase inhibitors will act as a fake nucleoside and prevent further action of your reverse transcriptase, whereas your non-nucleoside reverse transcriptase will bind at some other site and change the configuration wherein your nucleoside is supposed to bind for DNA formation. Okay. Now the tenofovir is actually a nucleotide reverse transcriptase inhibitor. Its prominent side effect is nephrotoxicity. So it decreases reabsorption of phosphate. Okay, that is why it is contraindicated in children less than 10 years and renal failure. Okay, the other drugs, raltegravir, we have dolutegravir here, or sorry, that is dolutegravir. Yeah. Now the side effect is lipodystrophy syndrome. Okay. For NNRTIs and protease inhibitors, the common side effects are rashes and increased risk of Steven-Johnson syndrome. Okay. Now there are very drug-specific side effects that you can find in your textbook. It's basically an exercise of memory, for that matter. Whereas your NRTIs, nucleoside reverse transcriptase inhibitors, they also have few common side effects which can be remembered by the mnemonic BAM. Bone marrow suppression, alopecia, and myopathy. Okay. Now moving on, we can talk about the drug regimens. Now the most commonly used regimen is TLD regimen, which consists of tenofovir, lamivudine, and dolutegravir. Now again, your tenofovir is contraindicated in children less than 10 years. For that, your tenofovir is replaced by pseudowudin. If the child is less than 5 years, your dolutegravir has to be replaced by lopinavir and ritonavir. So essentially there are three regimens. The first one is your TLD, the second one is ZLD, and the third one is ZLL/R. Lastly, this particular drug called nevirapine is given to reduce mother to child transmission of HIV and given to neonates born to PLHIV mother. Thank you.